Good. All right. Welcome back, ISSPT fans. Again, my name is Steve Oswald, physical therapist with Idaho Spine Sports PT. Today's edition is going to be all things neck pain. If you haven't been tuning in already, this is about the halfway point of what we had planned already, but we're likely going to do a bunch more of these videos after this. But so far, we've already touched on shoulder exercise for shoulder pain. We've touched on kneecap or patellofemoral joint pain. We've touched on vertigo earlier this week. And gosh, what else did we do? Oh, carpal tunnel. We did carpal tunnel. See, I should remember all these already. And we've got a bunch more planned in the future. I'll talk about that at the end again today. But thanks for joining me for all things neck pain. Ton of stuff on the docket today. I got a little ambitious with all the things we'll talk about. We'll see if we sneak it all in. If not, I promise you another video so that we cover it. And I do want to make sure that we answer all of your questions along the way, because this is for you. This isn't about me. It's about answering your questions and giving you the education and knowledge and empowerment to make the choices you need for your optimal health, for especially today dealing with neck pain. So our plan today is to talk a little bit about some of the primary causes of neck pain so that we know kind of what we're, again, dealing with and how to go about addressing your symptoms. We will talk about traction and use of inversion tables for neck pain specifically. We won't talk about that for back pain because that could be a different segment. We'll talk about a little bit of the exercise and hands-on approach that goes about treating neck pain. We'll talk about spinal manipulation or chiropractic adjustments. We'll talk about that today and actually demo one of those live. We will talk briefly about dry needling because we got a whole segment on that next week, but I do want to touch on it at least today. We'll talk about ergonomics and posture and that's influence. May talk imaging as well too. And lastly, what you can do for exercise if exercise hurts your neck. So again, as you can imagine, we got a lot. So I'm going to probably talk too fast today and breeze through things, but do leave your questions if we want to dive into some of these things more. So without further ado, our getting started, symptoms from the neck, again, can come from many different regions. What we do know through some of the studies looking at pain generators within the neck, the primary area that in most folks, at least 50% of cases of neck pain, comes about from what's called the facet joint in the neck. If we take a look at our spine, I pulled this out of a patient, by the way. Don't upset us, right? The facet joint are these areas where on the back portion of the vertebrae, they come together. And this is a joint. So this area kind of on top coming in contact with the one below, this space is technically a joint. It's an enclosed space. It's got a joint capsule. It's got fluid within there. It's a closed space. You have one on each side, and they kind of, again, come in contact with the segments above and below, right? They move and glide as we move. So again, if this is the back of the neck, this is the front of the neck, this is the back of your head, the skull. When we flex, those areas kind of separate. You can especially see that well down here where I flex that. They come apart. When we extend or look up, they tend to close down and touch, okay? Imagine kind of bending your elbow, how it kind of opens up the back of here, and then when you extend it all the way out, it's got a hard block right there because it closes down. We get a similar phenomenon here where it kind of opens and closes. What we also see with those facet joints is when we rotate or side bend, they tend to open up on the opposite side of the way you're moving. So if I bend to the right or rotate to the right, it's opening up this side. And that tends to reduce some of the irritation of facet joint related pain, again, generally speaking. So if you flex or rotate or side bend away from the side that hurts and it feels better, we may be dealing with a facet issue. What we oftentimes see too is a one-sided motion deficit. So you turn one way and you kind of feel stuck, and you turn the other way and it's fine. Again, we typically have a joint related restriction. It's not perfect, but that's oftentimes the case. We do have discs. You can see them here in the front. Okay. Most of the time, if we have a disc issue, like a disc bulge or herniation, it's on the back side and kind of out to the side. So we call it a posterior lateral. So it kind of pops out in a way this way. Most of the time, that is where the disc fails because that's where it tends to be weakest and where most of the forces are placed on it when we flex the head. You can get disc herniations in the neck, and the outer portion of the disc can refer symptoms, but most often the disc itself is not a primary pain generator in the neck. It can. Most often, if there's a disc-related problem, it's because the disc has encroached upon the space of one of the nerves that pop out and starts causing neurological issues into the arm. So numbness, tingling, weakness, altered reflexes. You'll see those phenomena happen with a pinched nerve. And if that nerve is irritated chemically, where there's some tissue trauma in the area, that's when you'll get pain that radiates down the arm. So there are other reasons for a pinched nerve too, especially as we age. There's just normal loss of disc height and maybe some excessive bony growth or arthritis that develops in the areas where the nerve pops out, and that can cause a phenomenon called stenosis, where there's less space and it pinches on the nerve. Again, that tends to improve with similar motions that help with facet-related pain, where you flex or you side bend or rotate away from that side and it gets better. So we may be dealing with an issue like that too, where there's an enclosed space where that nerve comes out. You can have pain from other areas. Again, commonly, especially in the neck, muscles do generate pain. Again, anywhere that has nerves in the body, it can generate symptoms. So especially posturally related pain. So if we sit for an extended period of time and we have more symptoms, if we tend to work for a living from a desk where we have to sit in this position here and the head comes a little bit forward, those just prolonged normal stresses will create excessive tension in that area and likely manifest with pain from what are called trigger points. And trigger points are kind of a key area for us to address with treatment so that we reduce the local irritation in that area and try to normalize the muscle. Now, most of the muscle that will generate symptoms in the neck, again, it's any muscle technically could, but the primary ones that we find that are symptomatic are what are called suboccipitals. They sit from the base of the skull and attach to the top two vertebrae, so they kind of span that area just at the base of the skull through here, okay? So it's those short muscles just right at the base. And then those muscles that come out to the side and attach to the top of the shoulder blade, these ones here, your upper trap, right, this big one, and then levator scap, which attaches to the top of the shoulder blade right there, so coming down and here. And so those pair of muscles are very much involved with helping support the head, control head motion, and are just a little bit more prone to those postural stresses where they kind of take the brunt of the work on. And they also can sometimes become overworked if we're having issues downstream from the neck. So as in shoulder issues or upper back issues, they tend to just be a little more active. Again, especially if you have shoulder issues, trying to reach up overhead, if you kind of get that classic, like, I'm going to reach like this, you start to develop overuse in that upper trap, and that can refer symptoms both locally, and both those areas, the upper trap and the suboccipitals, can refer symptoms into the head and create headaches. Now, again, I didn't want to talk about headaches per se today unless we have a strong desire to, because that's kind of a whole animal in of itself. But headaches coming from the neck region is a huge problem, right? And oftentimes is the primary issue with folks that are dealing with neck pain. It's like, oh, the neck hurts, but man, these headaches are killing me. So that is a phenomenon, and we can talk about that in almost its own exclusive video to do more with this, because it's a lot to unpack. Other areas that, again, less common, but do still create symptoms, tend to come from more traumatic issues. So if we've had a fall, or especially whiplash, again, those suboccipitals, we talk about a whiplash issue, can become symptomatic. You can sprain the ligaments that kind of span each of these segments. And again, those tend to stay a bit irritated over time. You can even have little micro trauma to the spinal cord itself, the sheath surrounding it, in a severe whiplash injury too. So there are other areas that can refer symptoms, but by and far, it tends to be the facet joint, it may be the disc, and it's those areas in between where those nerves come out, and then that surrounding musculature, okay? So those are our key areas that we're talking about, and each of those different areas will present its symptoms differently, and the target treatment may be different for each of those areas as well, because again, typically with treatment, again, you may attempt to target the inappropriate or altered anatomy, but usually it's driving your treatments based off of symptoms and kind of a cluster of findings on how you're presenting, because people with facet joint pain, they're not all the same. If you have facet joint pain and it's been a month versus 3 years, again, the treatments are different. Just because the other changes that may happen with the nervous system. So it's not all, okay, this is the anatomy that's wrong, we have to fix this. And that is an approach in medicine, both with shots and surgeries. And sometimes that's necessary to happen, but more often than not, we're attempting to address that whole region with a host of interventions to try to calm that area down and get it moving more. And that's the approach in therapy, at least. One of those key ways that helps to unload the neck, and oftentimes feels good, at least feels good for the majority of folks, is doing something like, we call it traction. Sometimes it's referred to as decompression. And I posed the question of using inversion tables for assisting with this. All those things help to separate the spine and create more space, both between the joints themselves and space between where the nerves come out. So anybody that's experiencing a pinched nerve phenomenon likely usually feels better when someone pulls on their head, or they use the door over the top traction unit, or maybe with an inversion table. Now, what we know from the research with using anything to kind of pull on the head a little bit to unload it is that you do see some success, some limited success, usually around 15% reduction in symptoms is what the research is showing us, at least, with using something that unloads the head with an even amount of weight of the head. So another way to say that is the amount of weight that your head has, which is usually somewhere around 12 pounds. If you have 12 pounds of force to pull on it, to unload it, it will feel better. But that oftentimes isn't enough to see long-term change. And so the research supports that more intense pulling from the head, somewhere around 20 to 24 pounds of force, or even more than that, and utilized intermittently, so not a constant level of pulling force, where the optimal ratio being around a minute of pull to 10 to 20 seconds of off time, doing that repeatedly for over 10 minutes at least, seems to have longer outcomes, and you can track a better outcome for at least six months to even a year using that method. Where you don't see that, if you're using the over-the-door traction unit that kind of pulls your head up when you're sitting, or using an inversion table where you're flipped upside down. Now, it doesn't mean that those are ineffective. It just means that if you're going to see symptom reduction with it, you're likely going to have to just keep doing it all the time. So inversion tables, cool, go for it. It likely won't help because it's only the weight of your head when you're flipped upside down with gravity to distract it. And when you're doing the door over the top, you'll have to control the on-off if you're going to see more success with it. Mechanical traction, which is what we use here in the clinic, looks like this, where you lay down and you place your head into the unit, it secures you in, and it provides that distraction force for you when you're laying down, so you have less effective gravity pressing down into those joints. And it automatically loads to an exact volume of pressure and then relaxes through that sequence to try to reduce your symptoms. This tends to work best with people with more chronic facet joint pain. That's what the practice guidelines suggest for us, but really especially those folks that are having a pinched nerve. So if you're having symptoms that go down your arm, and what we see from a cluster of findings that show that you'll be successful with it is if you're older than 55, you put your hand on your head and it makes it feel better. I know that's strange, but there's a reason why. Someone pulling on your head makes it feel better. And we have symptoms that are replicated when we do this motion like that. Like if you do that, it's like boom, it goes down your arm. If those things are present, you will likely respond very well to traction. Okay. So to summarize, inversion tables over the door, traction units, fine, but you'll probably have to use them long term. At least that's what the research supports. Intermittent traction with a little bit heavier force on and off tends to be more effective. Okay. Well, I'd be remiss to not talk about exercise a bit for neck pain, because that is frankly the gold standard for long-term management of neck pain. That's what all the clinical practice guidelines show us, not just with us in PT. The American College of Occupational Environmental Medicine, that has like a 700-page guideline, says exercise. Like that's like the key thing, education and exercise. So it's not just us saying as PTs, that's where it's at. Exercise is incredibly valuable, both in the sense of stretching to ensure optimal motion in those areas that you're restricted in, but especially strengthening and endurance work, especially for two specific areas in the neck: extending the head, so pushing it backwards, and then what are called our deep neck flexors. And these are muscles that sit right on the front of the spine. You can't touch them because you got a lot of anatomy in the way, like your trachea and your esophagus. You got a lot of stuff going on right here, so you can't touch them because they just run right along the front. Think of them as the core of your neck, Your neck is still your spine, and they help to provide more segmental stability. And we find that that specific region of the body is oftentimes either smaller or has some fatty infiltrate in it, or just isn't strong. It doesn't have the endurance necessary to perform its job well in patients with neck pain. So it's important to work those deep neck flexors. The classic way to do that is doing what we call a chin tuck. Everybody hates it when we cue it this way, but it's literally the motion of giving yourself a double chin. I will do it because we're on camera, right? I've got no shame. But if you're from a standing position, what you want to do from tall is literally just tuck. Okay? Imagine your head is like on a spit, right? And you're just twisting. What it's not is this bird kind of motion forward and backward. You're not going here like that, okay? You are just tucking, okay? Sitting doing that will be probably the easiest way to start because the way gravity is going to kind of fall onto your neck. You're not supporting the weight of the head as much there, and you can progress this to doing it laying down. There's all sorts of different ways to continue to get into those deep neck flexors, but the chin tuck motion is the kind of classic way to address that. I didn't plan on a lot of exercises today because there's so much content, but we can do kind of an exercise segment on this if we want to review more. But what we do know that's consistent with exercise interventions for neck pain is that exercise plus many other things tends to be better. And the same is true for any other type of activity for neck pain. What we see consistently over and over and over again, both here in the clinic and with the research, frankly, is that multiple interventions overlapping is far better than just one in isolation. So that's true for exercise even. Okay, exercise alone, good. Exercise plus hands-on, better. Exercise plus traction, better. Exercise plus manual therapy plus traction, better. So as we add multiple interventions, you have a higher likelihood of success, both in the short term and long term. So we want to mix things together. The combination of manual therapy and exercise has been showed consistently over and over and over again to be a useful and long-term beneficial means of treating neck pain. Manual therapy being massage, soft tissue work in the joints, and specifically manipulating the neck. So this kind of transitions into our manipulation talk. So when I say spinal manipulation is taking the joints within the spine, and here we're talking about the neck, and putting them into a position and applying a small but fast motion to elicit a change within the joint. Oftentimes that's accompanied by a pop, okay, or a click. And that click or pop is not necessarily something going back into place. This is a very, very common myth that's about in the world of rehabilitation and pain management, is that popping joints will put them back in place. And when we pop the neck, that cavitation, which is what we call the pop, is actually just a quick depressurization of gas particles within the joint space itself. Which is why within a few minutes, frankly 10 to 15 minutes, you can pop it again. And it's the same reason why when we pop our knuckles, you can pop them again soon too. All that gas will diffuse back in and you can pop it again. But that doesn't mean that nothing is happening there just because there's the diffusion of gas particles that we hear. When we manipulate the spine, it has a very pronounced and rapid pain inhibition signal that goes to that area. It's kind of bombarding to your nervous system when we pop it. Think of it as like a Control-Alt-Delete to your neck. So when we do that, it resets things, it calms it down, and it allows for more improved motion throughout the neck with less pain. And that's what we observe time and time again. Is you pop it, feels good, now you can move. And that's how it fits into our protocols is, okay, cool. Like if you feel like manipulation is going to be helpful, which is a good indicator that you're going to respond well to it, and we pop your neck, now we've got more motion and less pain that we can do exercise with. And that's where we're going to see a lot of benefit. Because what we see, and this was in a Cochrane review, which is a big systematic review that came out 15 years ago, I think, showed that just popping alone, you're not going to have good long-term outcomes, okay? It will improve things short-term, but you don't get better. So you can't just pop it and then just say, and walk away. You need to do exercise or some other intervention to make this better long-term. So it is safe to manipulate your spine. It is safe to manipulate your neck. We can go into probably a whole hour's discussion about how manipulation and the screening and risk for having a stroke, which comes up a lot in the media in regard to neck manipulations. But believe it or not, and again, I've got plenty of evidence to discuss this if we want to discuss it further, that popping your neck is safe. It just has to be on the right person. And so it is important to go through a screening to ensure that there's no underlying cardiovascular issues, that there's no underlying connective tissue or bone issues in that area, and that everything is safe to proceed. And if you've gone and done your due diligence with doing that, it should be effective, okay? We did plan on showing you manipulation today. So Amy, who's already our videographer right now behind the camera, she is kindly and probably openly volunteered to be our guinea pig today. So I'll show you so you can see how kind of light this is and how innocuous it is, but how effective it can be at the same time, okay? So we're gonna switch gears. We're gonna put this on the stand. Perfect. Right here. All right. So this technique that I'm going to show right now is targeted at that area that we talked about where the suboccipitals are, those first two joints. And this seems to be one of the best areas to address when we talk about manipulating the neck. Okay. What I want to do beforehand, since, again, I've already screened Amy. I've already screened her. She's safe to proceed with this. We want to take her and we want to just rotate her, make sure we have enough rotation there. So we just rotate all the way to the side, come out of that a little bit, because we're never going to be truly at end range. My hand's just going to be behind her like this, soft cradling position. We side bend, rotate, and pop. Okay, and she got multiple pops with that too. We're going to go to the other side. Position, side bend, up, and pop. And that's it. It's that quick. It's simple. It's light. Thank you, Amy. No problem. Right. However, what we didn't just do with Amy right now is follow that up with exercise and other things. Because again, popping it is good. Other forms of manual therapy, good. But we want to follow that with specific activities to ensure that that stays, okay? Have we had any questions about this so far? We're doing good? Okay. Additional interventions that oftentimes are overlooked or not commonly practiced by physical therapists, it is growing in popularity, both spinal manipulation. Again, you do need to be trained to do that. Don't get me wrong. Not every therapist feels comfortable or has the training to do a spinal manipulation. Here at Idaho Spine Sports, I do frequently. But another modality that's shown, again, consistently in the research to be helpful for specifically neck pain, especially neck pain related to overuse or muscle-related issues, is dry needling. Now, I'm only going to briefly touch on this today because, frankly, I've got a whole segment on it next Friday, again, like we talked about in the intro. But dry needling has been recently over the last year that it's been part of the scope of practice for physical therapists in Idaho. One of the key things that's changed the way that I practice and helps speed up and improve outcomes for patients more so than any other intervention that I've implemented. So I'd be remiss if we didn't talk about it. So set up the station here. I just wanted to show you what it looked like. Most of the time, dry needling, again, Cliff Notes version of this, we use monofilament or just single filament needles. They look like acupuncture needles. In fact, some of the ones I have are acupuncture. We do not apply acupuncture. Acupuncture is based off of Eastern Chinese medicine, using specific meridians where they place the needles to elicit exchange of body energy and change qi, right? The body's sensations and feelings, right? So we don't practice that here. We practice functional dry needling, or what's called trigger point dry needling, where we attempt to find the key area of dysfunction, typically from your perspective felt as a muscle knot, and within that knot or that trigger point, we utilize the needle, we put it into that area, move it a little bit to elicit some muscle twitching, which helps to act like that control to lead to that area, and normalize that resting electric current that's normal within our muscle tissue. It has a significant calming effect. What we see consistently is that it improves pain, both in the short and long term, and motion, just like it would with manipulation. So we get this nice window of opportunity to now implement specialty exercise to a greater degree, to a less painful degree, after utilizing some dry needling. Like most things too, dry needling is not effective on its own. It can help with the short term with reducing symptoms, roughly by 33% is what we're kind of averaging. But to see that big change, we want to implement other things. Common theme of the day, right? Oftentimes, in conjunction with the needling, once we put them into that trigger point, we may decide to leave that in and utilize electrical stimulation with that needle still indwelling to change that muscle's resting physiology and frankly get it retrained a little bit. It also helps with the soreness if we do some electrical stimulation with that indwelling. So the exact parameters are dependent upon the patient with how intense it is or how frequently we have that beating going. But we do introduce a little bit of electrical stimulation with that too, which is quite helpful. It's quite potent, it's powerful. It's one of the few things that we do in therapy that is a little bit invasive, but frankly has still little side effects, very safe, especially when provided by an experienced and confident practitioner. You should be safe with these. So again, we will talk about this in a whole segment on its own, so that's why I'm giving you kind of the Cliff Notes version today, but specifically neck pain. It's both got evidence empirically through the research that shows that it's helpful, but here within the clinic, it has been fantastically successful with certain types of neck pain. So that's a good one. And again, specifically with that posturally related pain or muscle related pain. Again, transitioning into posture's influence on neck pain. So posture is one of these things that most of us believe and assume is related to many of our musculoskeletal issues. And that is true for certain areas of the body. And it's a little bit inflated for others. For instance, posture actually, over the course of the last 20 years or so, we've seen that has very little to almost no influence on back pain. However, we do know that posture does seem to have an influence on neck pain, and specifically neck pain where we're developing headaches. So there is some suggestion that we optimize posture where appropriate for the upper body if we're experiencing neck pain, and to reduce some of that risk. So posture can influence neck pain and headaches, specifically when we are spending a lot of time or consistently find ourselves in a posture that we call upper crossed syndrome, or where we have this combination of forward head. So if you have a side profile, your head is a little bit forward and we're a little bit rounded in our upper back and our shoulders are rounded forward. This position kind of shortens certain anatomy within the body, and that can lead to overuse, and it kind of elongates others. The main issue with that position tends to be the fact that your head is displaced forward from the rest of your body and it's not quite pillared upright. What we've seen with some of the research regarding forces at the neck, it's that every inch deviation forward, which is roughly equivalent to every 15 degrees of an angle forward, every inch forward from straight up adds another 10 to 15 pounds of force that your head has to hold up. So if we are roughly 4 inches forward, so if I've got an extreme forward head posture, which we've all seen those people, or we've all seen those people, right? That's roughly a 60-pound head. And if you imagine 60 pounds of chronic tension spanning the anatomy of the back of your neck to try to support that, that's a lot of prolonged stress. And we start to develop that overuse phenomenon, myofascial trigger points, excessive strain in those areas. And again, it's not that you cannot be in those positions. You can be here, but it's the prolonged exposure to those areas or the lack of ability to move out of them, right? So if you have adequate mobility and you're only in those positions temporarily, posture tends to have less of an influence on your symptoms. But that's why we see office workers or people that sit and have sedentary jobs, specifically for more than 5 hours of sedentary work a day, start to develop or have a higher risk of developing neck pain because of the way that we typically sit, and especially sitting in an office where we're having to compute, where we sit, We bring our head forward a little bit to gaze and focus on the computer screen more, and our arms are outstretched in front of us to type. We bring ourselves naturally into that upper cross position where we are a little bit forward flexed, a little bit rounded, head's a little bit forward, and we're here. And we spend 5, 6, 8, 10 hours a day in that position. That has its wear, that has its effect on you. So the goal is to reduce that or eliminate it as much as possible. And that's why standing desks are emerging more and more in the office place, so you can modify your position. There is some evidence that a standing desk in isolation has its own problems, and so sitting all day, not good. Standing all day, also not good. What seems to be best is alternating, especially every 2 to 3 hours between those two workstations if you have access to that. So that's a key thing to do if you are a sedentary office worker, and most of us working from home right now, this is a problem, right? And even if you had an ergonomic setting at your workplace prior, now you're working from home and you may not have access to that. So it's important that you're changing position frequently. At best, the best case scenario would be changing or moving or stretching every 30 minutes. But minimum every 2 to 3 hours, you should be getting up and moving and changing position for at least several minutes to reduce those stresses, let the body reset. And optimizing that workstation as best as possible to facilitate your body being in good position. Okay, we see this commonly at the desk, and so I'm going to show you in a moment the best position to be sitting in at the desk. But this also goes for your vehicle, for your car. We oftentimes kind of slouch and sit too low and kind of ride the head forward in the car. I'm not going to show you that today, but the best way that you can find that you'll maintain a good posture and avoiding those positions is simply changing where your rear view mirror is set to. If you're get in your car, sit real tall in a good position where you feel like you've got great posture, you're tall, body's up, shoulders back. Look into your rear view mirror and adjust it so that is the setting where you can see well out the back. And that's going to be your consistent visual cue for you to stay sitting upright, because if you're not, you're going to slouch, you're going to look at the ceiling of your car every time you need to look in your rear view mirror. So subtle little tweak to make sure that when you're driving, because we tend to sit for a period of time when we're driving, that you can avoid some of those postural stresses, okay? Join me in my office. I'm going to show you an ergonomic setting here. All right. So, oh hey, I didn't see you there. So, this is my workspace, right? And this is fitted fairly well for me. The key things that you need to ensure when we're setting up our workspaces, think of it from honestly like arms down, right? When we are setting up our keyboard space, it should be at a height where when your arms are down by your side and your arms are at 90 degrees, so a big square angle right there, your keyboard and mouse are right there. It's perfect for me, right? So that's where this should be. If it's higher than that, if my keyboard was even just this high, I have to do one of two things typically. Well, one of three things. I either have to bring it away from me so I'm out here. I've got to shrug my shoulders to get up here, right? Or I've got to flare and do something like this. So I've got to do something wonky, right, to type. And that's going to lead to any one of those number of things is going to increase the stresses through here or in the back of the head as I'm trying to adjust my body. So I need to be in this low position here for my keyboard. Everything else should kind of move around that space. From this position, I want my screen, the middle of the screen, to be lined up with my eyes. This is a little low for me. That's okay, I don't spend a lot of time back here, right? But ideally this should be maybe a few inches higher, so the middle of the screen is bam, right in line with me. That way I don't have to look down at it, I don't have to look up at it. Laptops, which many of us are working off right now, that's tough, because if you're set up real well right here, you're looking down like this. So understand that challenge. There's no best way, so you're going to have to figure out that best way for you if you are experiencing symptoms. An ideal position is having that monitor right in front of you here. We do want it to be roughly 18 inches to 2 feet away from you, so you're not overstraining to have to be here, right? You want to be tall and have it be at an optimal length away from you where not to strain at the screen. Our back is tall, shoulders are back. You can see here I have a lumbar support. That's keeping me from sliding and sitting down too low like this in my chair, right, where I'm sacral sitting. If I slide down like this, I kind of flex my low back, but then I flex my upper back too. I bring myself effectively into this position. and then I'm going to have to tilt my head down to look at my screen, right? So you can appreciate that when I'm back here, if I'm hanging out for a while, I'm stressing my neck, right? And so, again, if I did that for 20, 30 minutes, not a huge deal. If I did it for 2, 3, 4, 5 hours, it is a big deal. Lastly, we want to think about our leg position. Again, you shouldn't be so high that you're not touching the ground. Knees should not have to be in your chest. You just want, ideally, roughly a 90-degree angle here. So this is set up pretty well for me too, where my chair height, my feet are comfortably touching the ground, spaced apart. My keyboard is still accessible. I don't have to move away from it. I'm tall. And the only modification that I need from here is maybe slightly higher. Okay. So that's our fitting. When you're in that position, you can reduce some of those forces that are consistently put on your body, specifically your upper back and your neck, that tend to accumulate and drive symptoms for office workers. Okay. So I can post a picture that has all those recommendations too, so you have that, because I know there's a lot of info rapid fire, but I'll post something that shows each of those things, and take it upon yourself to try. Modifying your environment as best you can, get creative, use old textbooks or stack stuff up, play with other things you may have around the home to adjust some of these things to fit it, because it will be worth going through that process of adjusting it around you, especially if you're already experiencing neck pain while you're at work. Okay, so that's it for ergonomics. We're still doing good on questions. Dang, man, I must be going through this stuff rapid fire. Okay, one more thing. Oh my gosh, we're doing awesome on time, better than I thought. So I had 2 other things I wanted to talk about today. One specifically, I wanted to touch on exercise if exercise hurts your neck. And this is pretty common, because it doesn't oftentimes take much as far as intensity or effort with any kind of especially resisted exercise, a strengthening exercise, to sometimes quickly and very pronouncedly increase your neck pain, right? Now, ideally, the exercises should be prescribed or implemented around those things or in conjunction with those things, and sometimes mild to moderate amounts of pain may be necessary to improve, but that would be kind of dictated by your healthcare provider or PT. However, if it's too aggravating, we do know that consistently, again, clinically, and then with the research, that working the areas in your mid-back has a protective effect and can improve the outcomes with neck pain. So working an area just below the neck that has an influence on the neck itself seems to have an effect with reducing neck issues. So simple exercises with bands or light dumbbells, or sometimes even the weight of the arm, can be effective enough to get the stimulus we need to see this effect happen. I'm going to show you 2 super simple exercises that you can implement at home using just a light resistance band. If you don't have access to a band, you can do this exercise with the same type of motion, with just an arm over the edge of the bed, going face down. But if I have a band, and if I hold it underhand for both of these, just holding it like this, I've got just a little bit of slacking when it's straight. Arms straight with just maybe a little bit of bend, so they're not locked out. A little bit of bend. Keep my shoulders low. I'm just going to pull it apart. Now control back straight. Okay. When I'm pulling it back, I'm paying careful attention not to let my head go forward. I'm keeping it tall, and I'm keeping my shoulders down. There is a tendency when we do this, as you pull back, to let your shoulders kind of shrug up like that. Okay. Keep your shoulders low. Pinch the tips of the shoulder blades in the bottom area together, going through that motion. Okay. Okay. Our second one, so that's our pull apart. Second one, we just bring it lower. Okay. Get a little closer together, because the motion won't be quite as big with this one. Elbows stay by your sides. Thumbs are still facing out. Shoulders are low, and pull it apart down here. A little bit of different muscles that we work with this one. This one will feel a little bit more in the back of the shoulders compared to the mid-back area. But same concept, okay? We don't want the head to jut forward. We want to stay tall. We want to keep the shoulders low. With this one, we need to be sure you're keeping your elbows close to your sides. As we get tired, it's normal for you to kind of start creeping out like this. Nope, keep it tight. Do not creep out like this, okay? Keep it tight, okay? Simple. 2 exercises, pull apart, then low pull apart. Both of those work most of that anatomy in the upper back area to some degree. And that helps to enhance and pull and strengthen things that keep you in that good postural position. So it opens you up and helps you maintain that strength to stay here in this tall position, and has a protective effect, it seems, for the neck itself, while avoiding actually working the neck itself. Now, if you're experiencing symptoms, even with doing that, it's likely that we're either getting a little bit too much of that shrugging motion, right? Where when we're pulling back, we're letting the shoulders kind of come up a little bit, keep them real low. Or the band intensity is just too high. We're getting what we call co-contraction, where the effort is just so much that all the surrounding anatomy, even if it's not really helping to move, contracts down because your body thinks, I got a lot of effort to do here. I got to tighten everything up. So you're facilitating too much muscle trying. So lighten up the band, or hold further apart so there's less resistance on it. We just want to bring the intensity down a little bit. So those two things would be modifications. Even that is painful. But mid-back strengthening is very helpful for specifically neck pain. I had some thoughts about talking about imaging today for your neck, x-rays, MRIs, things like that. I'm going to defer that to a different video. Again, we've got a series of videos that are planned still. I already have several more topics that I think will be appropriate to add, and I think maybe just something talking about screening and imaging in general, because a lot of things kind of fall into that, is going to be more appropriate. If you have questions specifically about use of x-rays and MRIs and stuff like that, leave them in the comments for now, and I'll get back to you. But otherwise, I'm gonna do a full video on that topic in and of itself over sometime within the next few weeks. Okay. So sorry I didn't get to that today. If that was the main reason you're here, probably wasn't. But if it was, we will get to that. I do want to invite you to our upcoming ones that we have scheduled tomorrow already at 1 o'clock. We have plantar fasciitis coming up. Next week, we've got hip bursitis, dry needling, and one other one, knee arthritis. Knee arthritis is the first one next week. So join me for those. Those ones will be good. Action-packed like this one was today. A lot of content today. We touched a little bit on a lot of things today, more so than probably in our other videos. So I hope that was helpful. Hopefully it answered your questions. If you didn't get a chance to view this live, or ask your questions today while you're watching live, please leave them in the comments, and I'll get back to you ASAP. But otherwise, thanks for joining. All things neck pain. Thanks, guys.